Well, welcome everyone to Your Health Partner, brought to you by Lehigh Valley Hospital, Hazleton. I'm Sam Lassant. Great show for you today. You know, I want to thank you for responding the way you're doing this health shows we do. You know, my wife and I always are told when we're someplace that, you know, they appreciate what the Lehigh Valley Hospital is doing in terms of bringing information to you. And today we have a great show. Dr. Brian DelVecchio is here, a rheumatologist, and they'll learn a little bit more about what's going on. So once again, my email is sam@ssptv.com. I do bring those messages to the respective people at the hospital and asking for different requests for different guests to come on to explain different things. But they have a website and they have all the information there. So today, Brian DelVecchio, tell me where you're from. I mean, you got a great background.
First, thanks for having me. This is a
My
great
pleasure.
opportunity. Yeah, I'm a fan of your show.
Thank you, thank you.
So this
Brian.
is a great thing.
Well, you got good taste, that's for sure.
Thank you, thank you.
Tell me about you.
Yeah, so you know, I actually I'm a local guy from Northeast PA, from actually a town, Old Forge, a close-knit, hard-working community, a little gritty community, just south of Scranton itself, and kind of goes by the moniker of the pizza capital of the world.
I know,
there.
I was just going to say, that's great pizza down there.
Self-proclaimed, but I think there's some credence to it, so that's a good thing.
When you were going into school, why did you decide to go into, first of all, become a doctor, and second of all, go into rheumatology?
Well, I'll start kind of in the beginning. When I was younger, my interest in healthcare kind of started as a kid. You know, actually in the town of Old Forge, when my dad would take me to the pharmacy, I was kind of intrigued with the pharmacist and the knowledge that a pharmacist had with regards to medications, how they treated people, and how professional they were. So that sparked my interest, and I actually did pharmacy school first. So I became a pharmacist, worked for a couple of years, really enjoyed that, but during my pharmacy training, I did some rotations in the hospital, and that's where my interest in medicine peaked, where I thought, you know, I want to do a little bit more and be more involved in the direct treatment and diagnosis of patients. So that's where I kind of peaked as far as my interest in medicine itself.
So why in the rheumatology?
And then rheumatology, yeah, you know, during medical school, doing some rotations, it was really interesting. I was really intrigued, and continue to be, with the really the complexity of the autoimmune diseases and the nature of the autoimmune diseases, and how they not only affect one organ system, but they are systemic diseases. So we'll see where they actually affect multiple organ systems. So it really touches on all the specialties and subspecialties of medicine, where we could kind of coordinate care and work with other people in the healthcare profession in different specialties.
You brought an interesting thing that affects your body. Explain that to us.
Yeah, so, you know, a lot of our diseases where we really it's a subspecialty of internal medicine, where we focus mainly, the focus is mainly on treating patients with various musculoskeletal conditions, most of which are autoimmune. So what ends up happening is, we know there's some trigger that occurs where there's a short circuiting of the immune system itself, and the body then is directed to attack normal tissue. And like with rheumatoid arthritis, it's mainly the joints. But again, they're systemic diseases, so other organ systems could be involved, excuse me, such as the eyes, the heart, the lungs, the kidney, bone marrow, etc. itself. We don't know what the exact cause of some of the autoimmune diseases are, particularly like rheumatoid, but we know that they're likely multifactorial with genetic factors and then some environmental factors. We know patients that smoke have a higher risk of developing rheumatoid. Certain occupations, silica, and air pollutants could help stimulate the immune system itself and cause that aberration in the immune system and perpetuate an autoimmune condition itself. We know certain infections. And also, it's interesting that where there's more and more data and information that rheumatoid could start outside of the joints, in mucosal surfaces. So
explain that to me.
Really, in the oral cavity, there's been some evidence of different infections in the oral cavity. In the gut, there's more and more information about the gut microbiome for a lot of autoimmune diseases itself. So there's an imbalance in the bacterial environment in the gut, as well as the lung and the oral cavity. And the bad bacteria can kind of supersede the good bacteria itself and lead to an autoimmune process, start inflammation, and could be a trigger for rheumatoid in the right genetic background for patients.
Okay, so now, how do I know if I have any of those conditions? Okay, I mean, like, what are the symptoms? You know, they just pop up, or is it my lifestyle? Is it like, and what are some of the illnesses?
Yeah, definitely. So for rheumatoids, our big kind of bread and butter, it's sort of like for the cardiologist, the heart attack. You know, that's
We don't want that.
We don't want that.
Okay.
We try to avoid that. But you know, it's basically a lot of patients will get, and it's typically over weeks or months. But there's different presentations. A typical presentation would be with rheumatoid would be pain, swelling, stiffness that occurs over weeks or months.
Where?
It likes the, great question. It likes the small joints of the hands, the wrists, and then the feet itself. Over time, it can involve larger joints. So, and then, you know, if this goes on over time and it's unchecked, this process, and we don't identify these patients, diagnose them, and get them on the proper treatment, it could lead to joint destruction, deformity, and disability. So we really want to catch patients early on in their course, get them on the appropriate treatment, because we know the earlier we treat them, get their disease under control, the better they do long term.
Does age have anything to do with this?
Yes, definitely. Age and actually sex. We know 2/3 to 3/4 of patients with rheumatoid are female. So we think there is a hormonal influence as well, too. It can occur in guys as well. The typical age is 30 to 55-ish or so.
Wow.
But there's juvenile rheumatoid. I will see patients sometimes, particularly guys like us, I guess we're behind the 8 ball here, where if you develop rheumatoid in the 50s, 60s, more of a robust onset where you could get multiple joints. So there's different presentations, but the takeaway point, the typical presentation is more swelling and pain and stiffness, small joints of hands, wrists, feet, occurring over weeks, months.
So that means, is it stiffness or?
Definitely stiffness. Patients could have difficulty with manual dexterity, making a fist, holding things.
Okay. So before a person jumps to conclusion, they say, oh, I can't move my hands. Before they jump to conclusion, I got this. What are some of the basic symptoms that a person should have to say, hey, we better call Dr. DelVecchio at the Lehigh Valley Hospital and get an appointment? Okay?
Right.
When is that? When do I have
so
to
that
make
would
that
look
call?
like more pain and swelling in the hands itself, the stiffness, a lot of morning stiffness where it could take a while for patients to kind of get going. Other symptoms of autoimmune diseases could be low-grade temperatures that are not explained by a infection, rashes, are different things that we see with our autoimmune conditions itself. Again, they're systemic diseases, so we'll see patients that can just not feel well. I may have this like kind of flu-like stuff, or I have a malaise, or I have low-grade temperatures, some weight loss, some decreased appetite itself. So because they're systemic diseases, you could have those symptoms as well too.
All right, so I know smoking is bad, okay? And what gets me is that the information we've had on smoking, but when you still see people smoking, I just feel sorry for them. I mean, I know it's an addiction and it's something, but we know that. So what are some of the things that we should do to help ourselves and sort of not get into this mess, you know,
Yeah, I mean,
health-wise?
you know, obviously smoking cessation, talking to your primary care.
Why
is
is smoking effective for rheumatoid arthritis? What is it?
Well, it can. It's a great question. It can affect the immune system itself, and we know there are different proteins that are modified in the joints, and smoking could actually accelerate that modification of the proteins in the joints itself that could cause this inflammation itself. And again, we know smokers, again, and the risk kind of persists for some time after you smoke itself. But again, it's a combination of risk factors. That's one of them. The family history too, although we'll see a good number of patients that develop rheumatoid that don't have that family history itself too. So we don't know what the exact cause is, but we know what signs and symptoms to look for itself too. That would be helpful to look at. You know, and even if we see patients say, should my first degree relatives be tested? Typically we don't test them unless they're having symptoms. So to make a diagnosis, we look at basically your history. patients with rheumatoid will have a different type of character of the pain itself and a lot of morning stiffness. And it'll be smaller joints, whereas osteoarthritis, which is much more common than rheumatoid, is typically weight-bearing joints, typically older patients. Worse, the more you do, and the back as well too. Rheumatoid typically doesn't affect the spine, other than one part of the cervical spine, but it doesn't typically cause back pain or any of those types of symptoms itself too. So, it's one of those things where we try to put it all together. So it's the history, the physical exam. A patient with rheumatoid will examine differently than somebody who has regular wear and tear or osteoarthritis. We take a look at blood tests as well to put the story together.
What are you looking for in the blood test?
The blood test, there's a rheumatoid factor and a CCP antibody. And the rheumatoid factor is probably not the best named test because in the context of joint pain, it helps you make a diagnosis. But I see patients who have a positive rheumatoid factor, especially a low titer, a small amount in the blood, that will not be rheumatoid. So some of our tests are not specific, whereas the CCP antibody, the other blood test, is more specific. So if you have a CCP antibody, a rheumatoid factor, along with a history consistent with it, and you examine that way, and then we'll also do some imaging of the joints, whether they be x-rays, ultrasound, MRI. So it's putting all those pieces together to make a diagnosis.
Gout. Now, you know how to prevent gout.
Mm-hmm. Right.
Take it from me. Okay, yeah. So you eliminate certain things. They tell you if your uric acid goes on. Is that part of rheumatoid?
That's not part of rheumatoid itself. No. Gout's a different type of inflammatory arthritis itself. And then even just touching on that, diet's important in that you could see patients have a trigger, to trigger a gout attack, but we typically don't just treat gout itself with diet because it only lowers the uric acid a small amount. So typically patients need to be on medicines if their uric acid's really high.
Wait a second now, wait a minute.
Yeah.
You're telling me now, giving me some good news here. You're telling me that, they say if you eat red meat or if you eat, fish, etc., the high things for causing gout. You're saying that 90% of that is not really as valuable as taking the medication?
Well, it's valuable in the fact that there are some of those foods could trigger gout attacks, but to manage it long term, just for instance, say somebody has a high uric acid. If you only did diet intervention, you'd only lower the uric acid a small amount, which would make you still susceptible for gout attacks. So what you really want to do if the uric acid level is too high and you have a history of attacks is get on a medicine that lowers the uric acid. Again, where diet is important is, I have a patient who loves shellfish. Yeah. So he'll end up eating some shrimp. He'll eat a whole plate of shrimp. Yeah. And he'll know that that'll cause an attack.
But he takes a pill then.
But then he'll take like a colchicine or something for an attack. But you really need to be on a maintenance medicine to lower the uric acid beyond a level to make sure that you don't have attacks.
Okay, so you have that for gout. So what do you have for rheumatoid?
Rheumatoid, there's a lot of different medicines that we use. They're typically the immunosuppressive meds itself because, again, we knock down the immune system to a certain point, which potentially can make you susceptible to infections, and that's where we go over. It's really having that relationship with the patient. You never want the medicine to be worse than the disease itself. Yeah. So there are immunosuppressive meds, there are oral meds. We will use methotrexate, hydroxychloroquine, sulfasalazine, leflutamide's another one. But then we have all these biologic medicines too, that are injectable medicines, that are IV medicines, and then we have medicines in between that are targeted synthetic medicines. So, we try to really match the intensity of the treatment with the severity of the disease.
Since you've been practicing 20 years, what changes have you seen in either technology or in medicines that help people with rheumatoid arthritis?
It's another great question. I've seen a lot of stuff. So many medicines have been approved in different mechanisms of action that it's really revolutionized what we do.
Yeah.
The first biologic was etanercept, was an injectable that was available in '98. So there's more than 20 years data on it, but since that time, there's multiple medications, different mechanisms of action that are available to us in our armamentarium to try to get the disease under control.
You were talking about diet with, with the gout. Okay, so what are some of the, first of all, what is rheumatoid arthritis? Describe that.
Yeah, so it's a chronic, often progressive, systemic, again, that's that systemic word with these systemic constitutional symptoms, autoimmune inflammatory arthritis that affects primarily the joints, but again, could affect other organ systems that, leads to these symptoms, again, pain, joint pain, swelling, stiffness, and then again,
do we know what causes those things?
That's the thing. We don't know the exact cause, but we know it's multifactorial. We know there's a genetic contribution. We know there are environmental contributions, like I talked before, like as far as smoking. Different infections could tip patients over if they're genetically susceptible. Epstein-Barr has been implicated. Parvovirus, again, the mucosal surfaces with bacterial imbalances in the oral cavity. Patients with chronic periodontal disease could have a higher risk of developing rheumatoid itself as well too. So we know that there's many factors that come together. It's different for every patient, and in the patient that's really genetically susceptible, that's where we can see things. I've seen patients even after a COVID infection. It'll stimulate reactive arthritis, and patients will develop rheumatoid itself. We could see a reactive arthritis to different infections. That typically is something that's a little bit different, but it could look like rheumatoid, and it could last for up to 4 weeks or so. So you really need to have the symptoms for at least 6 weeks in the appropriate joints with inflammation and rule out other causes of that to have rheumatoid.
So if to go over the symptoms again, so I'm watching the thing, and I have little pains or whatever. What are some of the basic symptoms that say, look, I better get a hold of Dr. DelVecchio and go and see him? What are some of those key things red flags that pop up?
The red flags that pop up, yeah. Again, if we're talking about rheumatoid arthritis, because we treat so many other autoimmune inflammatory conditions. We'll treat lupus, we treat mixed connective tissue disease, Sjogren's, scleroderma, inflammatory muscle diseases, vasculitis that could cause inflammation of blood vessels that could have various manifestations throughout the body. But from a rheumatoid standpoint, it really is that sort of subacute onset of primarily hand, foot, wrist, ankle pains with the pain, the swelling, and significant morning stiffness itself that we'll see.
Does exercise help?
Exercise could be helpful, yeah, definitely. And, and diet as well, too, trying to stay away from some inflammatory foods itself. That doesn't take the place of the medicines.
What would be some of those inflammatory foods?
Well, more all the kind of good stuff that I like, we like. More the processed foods itself, more the organ meats, the simple sugars, refined sugars. So,
but moderation is important.
Moderation's key. That really is key. But, there's some evidence, too, in smaller studies that, again, even changing diet itself as adjunctive therapy in addition to the medications could help as well, too. And there's more and more data coming out in studies as far as, changing diets and anti-inflammatory diets. Can they make the medicines actually work better?
Yeah, I was going to ask you.
Yeah, there's some data that even with methotrexate, sulfasalazine,
is that the biggest thing that you've seen in the 20 years you've been practicing?
That's a big thing itself. And it's a great thing because it empowers patients, too, to be able to make some changes themselves as far as diet, as far as lifestyle. It's always important, again, to help with the treatment regimen. We want patients to be active in their treatment regimen and really to be proactive.
I'm surprised you said that age group. I would think maybe over 65 or 70 you get more of those, but you're saying that age group is 35 and
usually, younger. And again, we could see it later, but the age group that we'll see later on is typically the osteoarthritis. So there's rheumatoid arthritis, which is the inflammatory arthritis. Then osteoarthritis, which is the non-inflammatory. And that's where you'll see that in the spine, degenerative disc disease.
Yeah.
People talk about wear and tear arthritis. But that's typically large weight-bearing joints. Although you could get it in the hands and you could get it in the feet. Different distribution than rheumatoid.
Where do you see the most of them?
For the osteoarthritis, really more the weight-bearing stuff, more the hips, the knees, and then the spine itself. But there's different areas of the hands. You could get it in the base of the thumb and then the tips of the fingers. Rheumatoid doesn't affect the tips, which is interesting. It doesn't, so you could see these little bony spurs or nodules, or nodes we call them, at the tips of the fingers and then in here and then the base of the thumb itself. That's more osteoarthritis. as opposed to rheumatoid. And most patients who are over the age of 50 that have rheumatoid will also have osteoarthritis as well too. So it's really trying to decipher what's causing the pain, because the treatment regimen is different.
So the sooner you get in to see you, the better. Okay, folks, I'm talking to Dr. Brian DelVecchio. I'm getting another free exam here, my friends. We'll be back right after this. Well, welcome back to Your Health Partner, brought to you by Lehigh Valley Hospital, Hazleton. I'm Sam Lassant. We're talking to Dr. Brian DelVecchio, a rheumatologist. Okay, now let's talk about where are you located at?
Yeah, so actually 2 locations. 4 days a week I'm in hometown.
Okay.
So
Great
that's right
place.
off of 309, south of
Yep,
of
going
Hazleton
well,
here. Yeah. And I'm there Monday, Tuesday, Wednesday, and then Friday. And then every Thursday I go to Pottsville.
Tell me, what's your philosophy when it comes to patient care?
Really is to develop that relationship with the patient, because these diseases I deal with are pretty complex, and again, multiple organ systems, and are often seeing other specialists as well too. So it's really trying to build that trust with the patient. So it's really patient-centered care, trying to deliver quality, compassionate care to patients, because these diseases, again, that I deal with, the autoimmune diseases, autoimmune rheumatic diseases, can really affect many aspects of patients' lives. So, and really, again, like I talk about, trying to match the intensity of the treatment with the severity of the disease. If somebody has moderate or severe rheumatoid, we want to give them the appropriate medication for that. If somebody has milder disease, we don't want to go in there with a big gun and potentially cause collateral damage and multiple side effects.
Give me a quick scenario of a patient. You have to mention the person's name, but give me a person who came in who had what and what you do for them. And
this was actually somebody I saw in follow-up a couple of weeks ago, but it was a younger gentleman in his 30s who had pretty bad psoriatic arthritis. So his skin rash was pretty robust and diffuse, and he had swollen joints. It was the left knee, multiple joints swollen in his hands. Difficulty, really was close to disability. He had a lot of difficulty at work. And from a social standpoint, very self-conscious and, again, with the skin disease and a lot of psoriatic plaques, flaking of skin, it wasn't really great for his social life. Talked to him, made him feel comfortable, went over the treatment options, and got him on the appropriate treatment. And within months, he was a different person. That's great. So he's employed full time. He looks forward to going out, outdoor activities and doing things. So really being impactful for patients and improving their quality of life is really what it's all about itself. That's the most important thing. And restoring function. I'll see patients who'll say, and you got to be realistic, obviously, I want to get back to doing the things I did before, and I can't because of my hands. I can't because of this joint. I can't because of that. So seeing them through and walking them through with that journey and being a partner with them, and then seeing them being able to do the things that they want to do is really fulfilling, and why I really want to do this and continue to do it.
The good news is that you don't have the magic wand to cure 100%, but you have enough that you're in a high percentage of bracket of curing these, of helping these people. Am I correct in saying that?
And a lot of our diseases, again, there isn't a cure, but we get patients into remission.
Yes.
And really what I like to do is sit down with patients, have them take a shared decision-making kind of approach and proactive approach, set goals with them to be as realistic as possible. If somebody comes in, they have long-standing rheumatoid with some deformities and other things, we try to get them to a low disease activity that may be more realistic than getting into remission. But we have certain cutoffs and things that we do, measures of disease activity that I'll talk to patients about and show them on a graph. You're here, we want to get you here. And really that visual is really an important thing for patients to say, hey, I'm here now. I want to get to here. What do I need to do? So setting those appropriate goals, I think, are important.
I'm going to ask you a dumb question.
No dumb questions.
Okay. How do you like working with Lehigh Valley Hospital?
Oh, it's great. It's been wonderful. It's a great system, and the integration with Jefferson has been great so far. It really has improved access of care for patients, quality care, access to multiple subspecialties. And the interesting thing for me is in Schuylkill County, my subspecialty is underrepresented. So I really feel like I could be impactful in treating patients with rheumatologic conditions itself. So, and their motto is people first, patients first.
So true.
You know, it really coincides with my philosophy, and it's been a pleasure so far.
Good. Well, it's been a pleasure meeting you again.
Thank you.
And I wish you the best.
Thank you.
Okay. Dr. Brian DelVecchio, information's on the screen, my friends. Great guy, and he enjoys Italian food. We'll see you next time.